Thank you so much, Andrew. I am so excited about today. Big, huge gratitude to all the folks who made this day possible, to everyone who submitted projects. Of course, the main goal of the day is to highlight and showcase all of the innovation that's happening in Alberta emergency departments. And I think you're going to see some really cool projects. Of course, the second objective is to get your mind off of COVID. And we are covering a wide range of topics. Is, of course, some COVID-related innovation and content that you'll be hearing about, but mostly what we are focusing on is what's cool and what's happening in Alberta's emergency departments. So as Andrew mentioned, I have the distinct pleasure of introducing Dr. Kendall Ho. Dr. Ho is a professor in the Department of Emergency Medicine at the University of British Columbia. And I've had the pleasure of working with Dr. Ho on a number of projects. His accomplishments are just too numerous to provide here in a short introduction. But what is readily apparent is that Dr. Ho is leading the charge for the transformation of unscheduled and emergency care towards the era of digital health. And he's doing so both with numerous research projects and innovations that you'll be hearing about today that are occurring in British Columbia, as well as work that's happening both on the national and on the international stage with WHO. So not only a great guy and a great emergency physician, but a super affable and approachable and collaborative individual. And we are super lucky to have him here this morning. So without further ado, our keynote speaker, Dr. Kendall Ho, take it away.
Well, Dr. Lang, thank you so much for this wonderful and very humbling introduction. It's my distinct pleasure, everyone, to be invited to the Emergency Strategic Clinical Network. I was looking through the program. I am as excited, if not more excited than HEiDi, in terms of different types of topics that you'll be tackling in, and such a wonderful learning experience. And again, thank you so much for me to be here to be able to do some knowledge exchange together and share some of the things that we're currently doing in British Columbia about the triage emergency system. As Dr. Lan said, I'm calling in from Vancouver, the traditional and unceded territories of the Musqueam, Squamish, and Tsleil-Waututh First Nations. And what I'd like to do is explore this area of the upfront when patients enter our emergency systems, and how can we as emergency medicine support our patients in their journeys right from the start. Next slide, please, Andrew. And again, Andrew, thank you so much for helping me with the slides. Emergency medicine, we're very used to the emergencies. The crushing chest pain, the strokes, call 911, come right in, and we will treat them. But of course, life has many kind of unexpected health issues. And so in this case, for example, a new set of parents with their child at 4 or 5 months old for the first time have fever, vomited twice, and it's Friday night, couldn't get hold of a family doctor. Or a person lying in bed and suddenly feel a little bit uncomfortable, not crushing pain, but this discomfort gnawed at him for about 10 minutes and went away. What should they do? How can they get help on those situations? Next slide, please. This is where the 811 experience has been installed. In fact, in Alberta and British Columbia are two provinces with great experiences with offering the 811 service. It's primarily historically been driven by health navigation and nurses to provide the clinical care. And in HEiDi, in 811 in British Columbia, they also have physiotherapists and also have dietitians and pharmacists to support the service. But think back to COVID, March 2020, when it first started. There was a sudden surge in volume of calls to 811. And people were calling in not only for their usual problems, but to say, do I have COVID? What should I do when I have these symptoms? Should I go to emergency departments? If I go to emergency, will I get infected? And these were very, very common questions. And in fact, within about 1 month, there was a surge of 6 to 7 times the call volumes of 811. And in fact, it reached often over 7,000 calls a day. And so at that time, myself with a group of physicians were organizing some real-time virtual support, a virtual care network in British Columbia. And 811 very kindly invited us to say, could you also establish a line of virtual physicians for 811? And that's when we started our affiliation with them. And if you look at the right column, there were 4 purposes for why we support 811 in working together on the virtual physicians or HealthLink BC Emergency iDoctors and Assistants, or we call HEiDi. The first is to address the information needs of our patients, but also to address the anxiety. This is really what a friend is about, that in fact, when you needed someone, that we by the phone or by the computer, being able to access and support our patients anywhere they are. Secondly, is to support the preservation of the acute care capacity, the emergency departments, the walk-in clinics, so that for those who don't need to be there, that we have this service to support our patients. But for those who do, we want to accelerate them going there, or for those who are already in emergency departments, that they can dedicate their resources to support those patients. The third is to support our patients to navigate our health system. It's not just a yes, emerge, no, but it's where would be the most appropriate place in the health system to support you. And the chronicity, what time should you follow up with the family doctors, and under what circumstance do you need to change? All those are very, very important. And finally, but very importantly, is how do we support our primary care so that when the patient's emergency is over, that we can connect them back to the family doctors, or when the patient's emergency accelerates, how do we accelerate them to go to emergency and still link up with their primary care doctors? Next slide, please. And so when we first started, there were 13 of us, family doctors, emergency doctors that got started. But from April till now, almost our anniversary day of April 7th of 2020, that we have now 87 emergency physicians and family doctors with experience in emergency departments in urban, regional, rural, remote, and indigenous communities across the province working together. And these are publicly funded physician support so that we can provide to our patients, and they can call in from anywhere they want. And one thing I'd like to emphasize is that in addition to the fact that we want to be supporting our patients like friends, but we are only part-time physicians. The reason is that we know that health professionals are needed. Now, my microphone just changed. Can you hear me okay? For some reason, my computer is playing a little bit havoc on me.
We can hear you fine now. Thank you.
Yes, great. Thank you. Great. And do flag me if for some reason my speakers no longer work. The point I was trying to make is this, that for the physicians, we do not want to take them away from the community and work in this full time. In fact, what we want to do is to preserve them in the community where they're needed, but just to borrow a little bit of their extra power to help us, kind of like grid computing, if you will, so that in fact, each of us need our own computer, but because there's 10% and we hook up a bunch of computers, we suddenly have computing power. So in the same way that these are part-time physicians working together provincially. Next slide, please. And so before 811, before HEiDi, this is how patients call into 811. And if the navigator decide that there's a health problem, they'll connect them to our nurses. And then our nurses will see the patient and triage them into, please call 911 right now. Or you need to see a doctor within 1 hour, either go to emergency, or if you can get a hold of your family doctor, go see them within an hour. Or yellow, which is to see a doctor within 24 hours. And black is to see a doctor within 1 week. And green is you can stay home. Next click, please. And so how we change in terms of HEiDi is that we take initially the yellow patients, the 24 hours, and later take up the MD to see a doctor within an hour. And now we've expanded to also include the emergency department. And I'll explain the reason why a little bit later. And by looking at that group, we feel that as physicians, we can make the biggest difference so that we can triage these people. If it's 911, it's obvious, go to emergency. But if it's, stay home, or you can see a doctor within 1 to 2 weeks, we can't really impact too much more. And so with that, we again talk with the patients either by phone or with patient's permission and physician's comfort, we go on a video like this and see the patients, and then we can triage them again. Next slide. And so this is a bit of demographics of the patients that we've seen since April of 2020, right up to January 9th of 2022. And so we found that, in fact, 63% of callers are female, 60% are within 20 to 65 years old, a younger age group, and 16% are the parents calling in because of their child, 0 to 4-year-old, and 15% are 65 plus. And you can see the graph on the bottom left of that demographics. And on the top right, our province, British Columbia, divided into 5 geographic health authorities. And so you can see that in those geographic health authorities, when you average it out to the calls per 100,000 patients, it's about even. It comes from all over the province, but there's a little bit increase in the islands. The top 10 nursing problems on the bottom right, you can see a list of them. Next slide, please. And so since April, we start with the yellow calls or see a doctor within 24 hours because we weren't sure whether we can actually get to the patient within an hour. And so we did a few months of practice, and we were able to then in November start to see patients that are triaged to red or see a doctor within an hour. And by and large, about 85% of the time, we could see the patient within 20 minutes. But then there would be some patients that we will still be able to see within 1 hour. But for most patients, we can see within about 5 to 10 minutes. And 28% being red calls, as you see. A one-day high volume for us would be 198 calls a day. Whereas on our average is anywhere from 123 to now rise to about 140, 150 with the 5th wave of the Omicron. And about 20% of the time, we use video. 80% of the time, a phone call is adequate. But for those 21%, video is indispensable. Doctor, I have a cut on my face. It's close to my lip. It's a little bit jagged, but it stopped bleeding. Do I need to go to emergency to have it sutured? I'm a little bit worried about COVID, so I don't really want to go. Or it's a funny case. I have a mom who had a child who fell off the bed about 4 or 5 feet on the carpet floor. Calls in half an hour later and said, my child has a really painful foot and doesn't want to walk on it. It's very swollen. Wonder if it needs x-ray. And so within about 2-3 minutes, I talked to my mom and said, well, why don't we go on video and take a look? And the mom was very good. You know, within about 10 seconds, we're able to get the video on. And we use Zoom, by the way, get the video on. And when the mom had the Zoom on, turn the camera to where the child was, the child's gone. And so for the next 30 seconds, we're trying to hunt down the child. In fact, he was rushing down the hallway and climb up the stairs, walking pretty good. And so it was easy for me to then say within about 5-10 minutes to mom, well, you know, in this case, why don't we just watch it a little bit and see how that goes. So video has a very particular way for us to be able to help diagnose. Otherwise, you know, picture words 1,000 words for sure. Next slide, please. And so as you see, we're by January 9th, we're close to 67,000 patients, and we're now pushing very close to 70,000 patients now. And we found that we would advise the patient on 1 of 5 actions that we discussed. You can see that in the first 2 columns, that for the nursing triage to say, see a doctor within an hour or emergency, that 7 out of 10 cases, we were able to divert the patient away from needing to go to emergency right away. In the first column, about 37% of 4 out of 10 patients, we can say, well, go see and follow a family doctor within 1 week. And then the second column is that 34% says you can probably stay home and there's no need to see a doctor at this time. These are the self-management tips. The middle column is important though. 15.7% we say you got to go to emergency. This is not indigestion when you're sleeping in the bed. This is really a heart attack. You got to go now. Whereas in this situation, we're able to then support the decrease in escalation of patients from needing to go to emergency departments. Next slide, please. We also look at not only these statistics that we track, but we also invite patients to to provide us feedback. The blue bars are the satisfaction rates, or positive. And we found that 90%, over 90% were satisfied with our service. The top bar was 17% that are not happy. They are not happy because they need to wait quite a bit of time to talk to the physicians. In the end, we are a interprofessional service with our nurses. Our nurses are doing a fantastic job. But very often, you can imagine that, in fact, there are 2,000 or 3,000 calls a day that the patients may need to wait up to about 2 or 3 hours to talk to a nurse. And then when we referred, we add on another 20 minutes to 1 hour. And so that's a long time for the patient to wait. And so we need to figure out how to continue to improve on that particular experience. Next slide, please. I think this is an important slide because we do ask the patient, do we relieve you or do we decrease your anxiety of the cases? And we found that in most cases, we're able to relieve their anxiety significantly, but still there are about 3% of the patients that we're not able to make any significant difference. I gotta say one case that was very important as the illustration of this anxiety. About 2 months ago, I got a 30-year-old husband calling in for the wife. The wife contracted COVID about 3 days prior, not immunized yet, and now experiencing quite a bit of short of breath. And that's a smart couple. They actually went and bought an oxygen saturation. Whereas the day before, the oxygen saturation is 95% plus. Today, when they call, the oxygen saturation plummeted to about 89%. And when I turn on video, it's very obvious that she was struggling with her breath. And so when they called, the question really wasn't, do I need to go to emergency, which is what they asked. But the question really was, if I go to emergency, can they help me, help my wife? Does she need to go to ICU? Can she ever make it out the hospital? And so in those moments, it's a privilege to me to be able to be in that room with them at their home and to reassure them that they need to go now. And there are ways that we can treat them and we can support them. And those are the moments that are things that really seared in my mind in terms of how these lines is not only about triage, not only about preserving capacity, but really it's about being human together. Next slide, please. And so what we are, so these are some of the experiences that we capture from our patients in terms of how they feel, what are some of the things that are able to overcome them, because these anecdotes, these stories are as important, if not more important, than the statistics that we collect that help our system make a difference. Next slide, please. Andrew, thank you. And we were able to publish our first paper in the CMAJ Open in terms of how do we capture our experiences. And really it's a plan, do, study, act cycle that we are currently going through a few iterations of where we are in the early phase of it, but we need to continue to improve. Next slide. In the last 5 minutes, I also want to talk with you a little bit about how do we use data to support us in a quality improvement. In British Columbia, there is the Health Data Platform. It's really about bringing different databases together for us to improve our health system as a learning health system. Next slide. And we're able to take advantage of this to participate with good privacy rules in place, of course, that we look at these databases, the 811 database that we talked about, the medical services plan for billing for the patients, the NACAR score, the PharmaNet, the DADS, the discharge abstract database, etc. So that the question we want to ask is, if a patient is touched by HEiDi, what would be this patient's journey after they've left HEiDi? It's not only us capturing and say, well, we have triaged 7 out of 10 patients away from emergency department, but did they actually go to emergency afterwards anyways, or did they stay home? And so next click, please. And so very fortunately, to be able to access this database, we really want to use data to help us to bring our performance into the fore and focus and say, what are areas that we really need to improve and what are actions that we need to take? And then we can look at the data again to say, have we made any changes? And this is where the dynamic of using this HDP is helping us tremendously. Next slide, please. For example, we're looking at this particular question as our first question to interrogate our data. of those callers that start November 16, remember, we didn't start RED until November. So November 16 to April 30th, our first cohort of RED patients, what are their 24-hour and 7-day healthcare utilizations categorized by the triage? So we want to see, you know, after we touch the patients, where did they go in our health system? Next slide, please. And so with that, we found that we have about 6,000 patients, or 5,880 patients. And we were able to triage these patients into those different categories that we talked about. These are the RED patients that the nurses classify for us, and then we sub-triage them into these different categories. Next slide, please, or next click. And so we found that out of these 5,880 patients, 62% are females, consistent with our data, and 60% of them have family doctors, so 6 out of 10, and 14% in rural locations, which is about roughly population distribution. And this is an interesting point, that economic dependency is capturing the patient's economic status, 1 being very good, 5 being underserved and economically challenged. And we found that our service biased towards those who could afford it. And so this is one of those learning points for us to say, well, how can we make our service better so that we can really serve people equitably? Next click, please. These are really the important data for us. We found that for those who we as physicians recommend going to emergency departments, that 62% went there within the first 24 hours. In the literature, we're able to find that in general, telephone service, the concordance rates of
patients. I will turn you to a crisp if I do.
Patient following the advice is about 50 to 60%. So we're about even there. But the question was, how come when we make the recommendation that 62% went, but 40% didn't? How can we improve? Or are there things about the recommendation or the patient's decision themselves not to go to merge? We also found that for the 0.7% of the RED patients that went that we touched, 0.7% got admitted to hospital within 7 days. And then the third category, for those who we recommend going to see their GP within 1 week, that 50% of them did, based on the MSP coding. When we look at the RED category of mortality, we found that the mortality is 0.08% within 7 days. And we assume that any mortality beyond 7 days is probably not related to alcohol. And so with that, we found that the average mortality rate of discharge from emergency department in British Columbia was 0.1%. And so it's nice to be a little bit lower, but maybe we should be pressing even lower for that mortality rate. And then finally, this is reassuring for us that for those patients who we recommend going to stay home, that there was 0% mortality for those within 7 days. And so these are the data that help us to start uncovering some of the things that we do, but we need to now look at our protocol, look at our health system to say, well, how can we increase the concordance of patients to our advice? And so I hope that we will continue to be able to report on these. Next slide, please. And so in conclusions, ladies and gentlemen, that I hope that this is a bit of an illustration of how continuous quality improvement is vital to the heart of what we do. But at the front of the health system, that we're able to use virtual to support our patients. Can they stay home, or do they need to go to emergency? If they do, what are some of the things that they need to do? But if they stay home, how can we be a friend to support our patients so that we in emergency medicine can really contribute to a very unique slice of the healthcare system between community and acute care? Next slide, please. And obviously, I'm speaking here on behalf of a group of us that work together with the Ministry of Health, British Columbia, Doctors of BC, First Nations Health Authority, Provincial Health Service Authority, and University together to support this system. So thank you very much for your attention. I look forward to some Q&A and also hear your thoughts and learn from you in terms of this approach. Eddie, may I hand the time back to you?
Absolutely, Dr. Ho, and thank you so much for such an inspiring and informative presentation. Definitely, I think you are providing a crystal ball of insight into what the future of emergency care and unscheduled care can look like.